All set, everyone? Ariman, you're there?
Yes, ma'am.
Yes, ma'am, I'm here only.
And you can hear me properly?
Yes, yes.
Yes, ma'am.
Fine. So, what is the flow? Who is starting?
Ma'am, Kavya will start the introduction. Later, she will introduce you. Then, after your presentation, she will introduce the speaker.
Okay, done.
Okay.
Okay, I'm here. Once everyone join, then we can start.
Okay, ma'am.
Speaker has not joined yet.
No, no, no.
Okay.
Like, it also like forwards directly on.
Hello. Hello. Has the speaker joined?
No, ma'am, not yet.
Okay.
तो भी आए 1 बज गया।
Participants, either 13 of us are us only, I guess. I mean, at least 10.
आयुषी मीटिंग ज्वाइन कर दिया पानी ले Good afternoon, Dr. Ghosh. Can you hear me?
Yeah, hi, I can hear you.
Hi. Yeah, I'm Dr.
Hello.
Kavita. Nice to meet you.
Hello. Hi, yeah, nice to meet you too.
Yeah. So if everyone is there, can we start the webinar?
Yeah, okay. I'll just share my screen and start.
Okay, so I'll just briefly introduce the concept and the content why we are hosting this, and then you can start.
Sure, yeah,
Uh,
of course.
yeah, housekeeping requests. Please keep yourself muted.
अपोन एकदम मस्त है ये पूरे शहर में सबसे बड़ा बेडरूम
Over to you, Kavya. We can start the webinar.
Okay, ma'am. Okay. Kindly, please, can everybody be on mute? Yes. Thank you. So today we are having a ISPO webinar, KIHT ISPO webinar. So esteemed speakers and participants, on behalf of Kalam Institute of Health Technology, I extend a warm welcome to this webinar on leveraging real-world evidence in HTA to combat antimicrobial resistance in hospital settings. So KIHT is a dedicated to advancing healthcare innovations, driving research, and influencing policies that improve medical technology and healthcare solutions. As an organization for ISPOR India chapter, KIHT actively supports research in health technology assessment, pharmacoeconomics, and real world evidence generation, all of which play a pivotal role in evidence based decision making in healthcare. With the growing challenges of antimicrobial resistance, today's session will explore how HTA frameworks can use real world evidence to improve healthcare decisions and infection control. To officially start this session, I'm happy to introduce Dr. Kavita Kachru, COO of KIHT. Dr. Kavita Kachru has 16 years of experience in healthcare policy, innovation, and leadership. She has contributed to major national and international healthcare projects and has made a significant impact through her research publications. Ma'am, we welcome you to begin the webinar.
Thank you, Dr. Kavya, and it's a pleasure to have Dr. Ghosh with us today for this for discussion on this very important topic. So, welcome everyone. Welcome, Dr. Ghosh. We are privileged to have you here today. And being the Chief Operating Officer of Kalam Institute of Health Technology, I would just like to give a brief overview of what Kalam Institute is and what do we do. So next slide, please. So as you can see here, Kalam Institute of Health Technology has been set up in the name and honor of Dr. APJ Abdul Kalam, and it's one of its kind globally. The project was funded initially by Government of India, supported by Department of Bio. Please mute your mic. Yeah. And we are also a WHO collaborating center for health innovations, contributing innovations globally. It also draws its credibility from the fact that Kalam Institute is housed at AMTZ, which is world largest medical device ecosystem and manufacturing cluster in India. As Dr. Kalam once said, innovation distinguishes between a leader and a follower. With this in mind, KIST is leading the charge to transform healthcare innovation globally. And that is what is a concept behind this webinar series. Kalam Institute of Health Technology is leading all Indian ISPOR chapters in driving evidence-based healthcare in India. As you can see in the next slide, please. Next slide, please. No, yeah. Next, as you can see in these slides, we have many different verticals at Kalam Institute of Health Technology. First vertical is Center for Health Technology Assessment. We do lots of health technology assessments for Government of India. We are also we have also partnered with Health Technology Assessment International HTA. We are also a price monitoring resource unit for Government of India, National Pharmaceutical Pricing Authority, and we do lots of drug pricing HTAs with them, and even drug vigilance in India. We're also a center for primary research and development. We have a very unique center named as CMIT, Center for Market Intelligence and Trade. Under this center, we do lots of market export and import data analysis. Then very uniquely, we have Center for Technology Transfer. Anybody, if you have a technology, you can register on the portal and it gets transferred to the industry and industry can uptake the innovation. Very transparent process. So if anyone has an innovation and they want to, they want industry to know about that innovation, they can register themselves in this technology transfer portal. We also have an in vitro diagnostic testing kit center, Center for Certification Services for MedTech sector, and Janaushadhi Kendra. On the other side, we are also a JBI affiliated group. We have also partnered with ISPOR, as you can see, because we have partnered with ISPOR. This is a webinar series which leads to strengthen this partnership. We also have World Health Innovation Forum. We host every year World Health Innovation Forum in the month of December. You are welcome to participate in this World Health Innovation Forum, which includes participation from around more than 100 countries. We also have an international journal on health technology and innovation. If you have any publication, we welcome you to submit to this journal. We can help you in publishing as well. We are also very recently partnered with the University of Washington and Washington Start Center. So we will be doing lots of research work with them. We also have a center named as the Ministry of Electronics and Biophysics. Last but not the least, we have a Kalam Blood Bank as well, because inside our campus, we have a Make in India hospital. Now coming back, so this was just an overview of how Kalam Institute is contributing to this entire ecosystem of healthcare and evidence-based research holistically. Now, coming back to the concept of this webinar series, why this webinar series and how we are contributing and strengthening the evidence-based ecosystem in the country. So with ISPOR, we would be doing the webinar, a webinar every month. We are updating pharmacoeconomic guidelines. We are also helping to build the capacity to do HTA in all these centers across the India. Next slide, please. Yes, so this is the overview of the webinars which we would be hosting over a period of 9 months. So today's webinar is the second webinar in this series. Next slide, please. Now, coming to the ISPOR activity. So that was the background of Kalam Institute. Now, I would also like to share some glimpse of ISPOR Global, what activities and how actively ISPOR is contributing to evidence-based healthcare globally. So as you can see, there are special events during ISPOR. So these are some glimpse of special events of ISPOR during 2024 and Europe conferences. So total events recognized, so the 13 regional chapter meetings, 13 events for students and new professionals, and 11 events with regional focus. The main forums and meetings were ISPOR Latin America Consortium, Industry Committee Forum on real world events, which we're talking today as well, ISPOR Africa Network, ISPOR Asia Consortium meeting, ISPOR Central and Western Europe Consortium meeting, student and faculty opening meeting and roundtable, new professionals in HEOR, first global leaders meeting at ISPOR 2024, presenting ISPOR's global initiatives and recent developments in Asia Pacific, Latin America, Africa, Middle East, and etc. Next slide, please. Coming to ISPOR regional activities again, so forums and recognitions, main forums which happened in 2024 were ISPOR Asia Pacific Consortium, Arab Network, ISPOR Central and Eastern Europe Consortium. Key initiatives what were taken during these forums, and in the 2024, the ISPOR Central and Eastern Europe Consortium launched a new research project on transparency in health technology assessment, CEE, presented at ISPOR Europe 2024. New leaders were incorporated into ISPOR's global group, including chair and president-elect positions in regional consortia and networks. Outstanding chapter recognition is for Saudi Arabia, Kazakhstan, Mehrab, and outstanding student chapter were also nominated, and that was King's South University. Next slide. is for regional collaborations, Asia, Africa, Latin America, is for Colombia Conference, Latin America, HTA Roundtable. And these are the glimpse of different ISPOR regional collaborations and what all has happened and how ISPOR is contributing immensely in the global evidence ecosystem. So next slide. Advancing HEOR in lower and middle income countries, expanding access to HEOR through the LMIC initiative. So ISPOR has also announced new initiatives. So now previously there were less travel grants, now they have increased it to 90 travel grants and awards to attend ISPOR conferences. More than 15 chapter educational activities were supported. Over 900 fee-waived ISPOR memberships were provided. New initiatives, resumption of educational grant program for student chapters in LMICs, review of membership and conference price points for accessibility, introduction of LMICs, prices for the ISPOR Europe Digital Conference Pass, new membership package with 25% group discount for ISPOR chapters. Recognitions is for LMIC Student Chapter Award, recognize the D.Y. Patil Institute of Pharmaceutical Sciences and Research in 2024. So these were some activities, what all has happened and how it has contributed. So what are the upcoming events now? That was what has happened in the previous year. So what are the opportunities for you all in this upcoming year? So sport is happening in 2025 in Montreal, Canada, from May 13 to 16. You all should save the date. Collaborating to improve health decision making for all, expanding HER horizon. That's the theme. ISPO Real World Summit. That will be happening in Tokyo, Japan, in September 28th to 30th. ISPO Europe is happening in Glasgow, Scotland, from November 9th to 12th. So you all, if you want to visit, if you want to attend, develop connections, meet people, you all should, plan for all these upcoming events. So strategic collaborations, the ISPOR has collaboration with Gates Foundation on HTA and HER training collaboration agreement. ISPOR in India, as you have seen, this event is happening because we have a collaboration with ISPOR, expanding outreach within Andhra Pradesh MedTech Zone and Kalam Institute of Health Technology and 8 regional and student chapters, updating pharmacoeconomical guidelines, educational training seminars, participation in Global Health Innovation Forum. That's what I mentioned you. That's what is shown in this slide as well. Last but not the least is for Hero Awards, HUR Awards, recognizing excellence. You all are open and you all should, if you are doing work or if you want to contribute and if you want to get recognized, then you should apply for this awards. At this point of time, nominations are open for and there are different categories where you can apply based on your background and work. So I encourage you all to apply for this award. As you can see here, ISPOR also has a open access journal named as Value in Health, all fee waived for papers submitted from January 1st to December 31st, 2025. So you all are encouraged to submit your research papers in this journal, which is very reputed with good impact factor and it's well known globally. Next slide, please. So how to get involved? You are supposed to submit an abstract or full-length article according to the instructions which are there on the website, and then you can apply for it. Next slide. With this, thank you so much. And let's welcome our speaker and start to get engaged on the enlightened discussions. And this topic is very interesting and we need to understand the real world evidence on antimicrobial resistance, because these days everyone is suffering and we need to understand this topic and see how we all can collaborate on it. If there is any need, how can we work together? How can we actually make a difference in the entire ecosystem by joining hands together? So once again, welcome Dr. Ghosh to this webinar series. Over to you, Kavya, for the brief introduction for our speaker. Thank you so much.
Thank you, ma'am, for your valuable words that set the stage for today's discussion. Now, next, I would take the privilege to introduce our expert speaker, Dr. Pinaki Ghosh. Dr. Pinaki Ghosh is a leading expert in health economics and market access, HER, with 18 years of experience in evidence based healthcare, reimbursement strategy, and policy advocacy. Currently, he serves as a Director of Health Economics and Market Access in Asia Pacific at B. Braun Medical Malaysia. Holding a PhD in Pharmaceutical Sciences from Bharati Vidyapeeth, Dr. Pinaki Ghosh specializes in HTA, economic modeling, and real world evidence generation. His expertise has been instrumental in shaping policy reforms and securing successful reimbursement approvals across Australia, Thailand, Korea, and Taiwan, and the UK. Dr. Pinaki Ghosh, we are honored to have you with us today. The floor is
Once,
yours.
yeah, once again, if I may ask all the participants to please switch on your camera so that we can take a very nice group photo because I can see we have good 41 participants with us. Let's take a photograph and let's capture this moment and then stage is all yours, Dr. Ghosh. Please switch on your
Sure.
cameras and I request my team to capture all the audience as much as we can. And once we are done, Kavya, you can give me a thumbs up and we can go back to Dr. Ghosh.
Yes, ma'am, we can begin.
You're done? Okay, thank you. Over to you, Dr. Ghosh. And
Yeah,
welcome.
thank you so much, Dr. Kavita, and yeah, I think I would, I mean, at the beginning, I would just say that there's one more thing I want to add to KIST. KIST has a very nice fellowship in HTA, which I was also a part some years ago. So I
Yes,
think that
thank you
is,
so much for
yeah, that's
highlighting that. Yes, very
what,
recently we hosted it. It was 10th International Fellowship from 10th to
yes,
15th March, and we had participants from across the country, east, west, north, south. It was very successful. Thank
yes,
you for, starting your talk with that. It actually
yeah.
is so gratifying for me to hear that. Thank you
No,
so much.
it's very it's a very nice fellowship. I would say that people who are listening to this, they should take privilege of this kind of fellowship. Firstly, it is not there in India very frequently, and you have esteemed professor from US, Professor Antimicrobial, who usually comes there. So I think if you are lucky enough, then you would get a session with him, and believe me, it would change your lives for better. So go to Vizag whenever this fellowship happens. And I think another very nice thing that I noticed was your white paper on HUR, which you are writing, and which is, I think, needed. And secondly, you also mentioned about a lot of activities which you are doing with the industry. So that part is extremely important because when we talk about HTA in medical devices, I think KIHT is a very unique place for that, where you have dedicated people who do work on HTA for medical devices. I don't know any other place across the world where HTA, I mean, the medical device HTA has so much prominence. And I mean, being transported from pharmaceutical world to medical devices around 8 years back from myself and doing HTA, I would request people who are in medtech HTA area, they can definitely consider going to KIST, learning from experts, and definitely being a part of this webinar. And also the very nice journal that you have started on HTA is a really, it deserves a lot of applause. coming from a center of excellence which has JBI accreditation. Although I don't know whether Dr. Sharma is a part here, but my regards to him to start my
Yes.
presentation.
Yes,
Yeah.
actually, he's traveling, otherwise, he was here. So it's like you have done a third party validation, and you won't believe how satisfying it is for me, because I'm meeting you first time online. I don't remember when which fellowship you attended, which batch you were in.
I was in the second batch.
Oh, very nice,
It's
very
very,
nice.
very old.
Very old. Too good. Too good. Yes.
Yeah,
So
yeah,
very
yeah.
nice. Yeah.
Yes.
So Dr. Sharma is anyway. This is a live session, and
Yeah.
hearing such words, I think you. So basically, because it was an sport session, so I tried to focus more on sport and less on
Yeah.
all the activities. But believe me, whatever I intentionally didn't boasted about KST, you covered it all.
Yeah.
So thank you
That's
again.
no need for that. But I think that's what Dr. Sharma is doing for, I think, all his life. So we need to definitely highlight that. I'll share my screen, and do let me know if you can see my screen and my voice is clear and
Yes.
everything is
Yes.
clear or not. It's okay now.
Yes. Yes. We can see. Yes.
Okay, I will. Yeah. All right. Okay. So this was the topic which was given to me. I would not read through the topic. I'll just say that I'll talk about real world evidence in AMR, antimicrobial resistance, uh, in a broad way, but I would have some special attribution of data to India, and what is happening across the globe, maybe more from a data science perspective, and what it can do to India now, and that too in a hospital setting. So first, going into the presentation, I have a declaration that currently I'm working with B. Brown, and the data, information, opinions which I expressed in the webinar are completely my own, and they don't have any relation to my employer, B. Brown Medical Industries, which is a leading manufacturer of medical devices. And yeah, so but this current presentation is entirely my own, and it is not related with my employer. Yeah. So if you want to know more about B. Brown, I think you should go to the website and see. But currently, we will talk about three parts very clearly. What we should talk about any problem is why, how, and what. So just three points. I don't have many bullet points going through a big lecture type of session. For me, this should be a very informal session where we should have interaction maybe during the course or later on. But for me, only 3 points: why, how, and what. So coming to the why part, within the why there is a small what. So that is what is antimicrobial resistance. I think at this stage, when we are as an audience, or all of us, we very regularly consume a lot of antibiotics. I myself, as long as I was in India, I used to fall ill in February and October because of season change and sore throat. Of course, I was in Delhi that time, and I usually consumed cephalosporins or azithromycin. Many times, I would go to a doctor who would prescribe me this, but most of the time, I never got an antibiogram for myself. I never got, I think, an antibiogram done for myself. So I didn't know actually whether or not I should be getting that dose or that particular antibiotic. Why not a sulfa drug, which is a previous generation? So basically, the definition of antimicrobial resistance is when microorganisms are not inhibited by usually achievable systemic concentration. This is a bookish definition, but usually what happens in a clinic or a hospital setting is, if you undergo, if there is a antimicrobial resistant strain, then you usually have to titrate the volume of the antibiotic, or you have to change the antimicrobial agent which you are using. and that's there is a ceiling to this to which you can go, and that is why it is so threatening for all of us. Coming to the timeline, so if you look at the development of antibiotics, the drugs, so right from 1930s or late 20s till 2005-6, you have a series of antibiotics which have come to market, driven by top-notch companies. A lot of research has gone into creating them. Of course, they have been handed over to our healthcare workforce to cater to different microorganisms, gram positive and gram negative, both in wards and in ICUs. However, you have some antibiotics which are very specifically useful in ICUs. For example, linezolid. This is a ICU.
Sorry to interrupt, Dr.
Yeah.
Pinakikos.
Yes.
Your slides are struck, I guess.
Yeah. No. I am at the same slide.
Sure. Thank you.
Yeah. You are at the timeline, right? Timeline.
Yes, sir.
Yeah. I'm still here. Yeah. So I would just
It's
say
still
that
the introduction slide.
no, I'm in timeline of antibiotic
No,
resistance.
we are able to see only the introduction slide, the first one. Yes.
Can you see now?
Yes. Thank you.
Okay. Yeah. Can you see now the timeline of?
Yes, we can
Okay,
see
all
that.
right.
Thank you.
Okay. Yeah. So over the years, I think from 1930 to 2005, you have seen many antibiotics develop over the period, and over the last period, you can see that those antibiotics which are usually used in Indian ICUs. So I was just talking about linezolid, which is a specified ICU, which used to be a specified ICU medication, and I think as children, when we grew up, we consumed a lot of cephalosporins, and now when we see even the younger ones, 1 to 2 year old, they also have cephalosporins. So the we are reaching the ceiling very quickly these days. Is the slide changing now? Okay.
No, we are in the timeline. Can everybody be on mute, please?
Can you see the slide changing?
Now, yes, we can see now. No. Again.
Wait. Why is it? Can you see my slides?
Yes. Now, burden of AMR in India.
Yeah.
Yeah, thank you. And can you please put it in presentation mode?
Yeah. I put.
Yeah, thank
Is
you.
the slide changing now? Can you see the slide change?
No, it's still in the burden of AMR.
Now?
No.
There's a problem, I think. Wait a minute.
So I think you can once try to share your entire screen because there is some issue with Zoom also when you're sharing only the tab. So if you share your entire screen, it would work better.
Yeah, can you see now? Entire screen?
Yes, this is perfect.
Slide changing?
Yes.
Okay, all right.
Yeah,
So,
thank you.
yeah, all right. Yeah, thank you. So coming back to what happens within a hospital. Suppose a patient enters the hospital, and around 10% of the patients usually get hospital acquired infection. Out of them, around 25 to 70%, they get the hospital acquired infection due to poor hand hygiene. This is as per DDAPT. Now, this HAI which they acquire is definitely preventable if you use a proper hand hygiene procedure or a hand hygiene agent. And a part of this is usually the HAI, which is due to AMR bacteria. Another data which says about 25% of this HAI is usually AMR bacteria, which can be prevented. And this is the importance of a simple hand hygiene which you can do in a hospital, which is usually not so well done. Maybe the 5 moments are not well practiced, but it leads to a lot of AMR bacteria. There is a lot of data which is there, but I would like to tell you one data which has been highlighted by Lakshmi Narayan. Is every 9 minutes one child dies in India due to AMR. So this is one specific data element which I would like to highlight. Whenever we talk about AMR, we should know that while we are talking every 9 minutes, we are losing one life in India due to AMR. So I think that is the depth of the problem that we are talking about. Another very stark observation that you would usually do in India is Western ICUs versus Indian ICUs. So Western ICUs have a lot of gram-positive organisms, whereas Indian ICUs have a lot of gram-negative organisms. The global, the global organisms are slightly different than our organisms. Our organisms are usually gram-negative, and they include things like beta-lactamase resistance, extended spectrum beta-lactamase resistance, carbapenem resistance, etc. Now, gram-negative AMR is slightly more difficult to treat and cure than gram-positive AMR. Why I am saying and highlighting this piece is because there is a lot of data on AMR and Indian AMR, but there are a few things that we should all know. One is that every 9 minutes there is a life lost. Indian ICUs are different than Western ICUs. Indian ICUs have gram-negative microorganisms, and they are difficult to treat than gram-positive ones. So we need very specific way and very specific, I would say, data capture mechanisms as well as the treatment regimes. This is a data, I think it's from ICMR, which talks about different kinds of strains which have resistance, and you can see all these are resistance strains which include Acinetobacter baumannii, Pseudomonas aeruginosa, Klebsiella, E. coli, and all that. So basically, this is very sanitized data. It's coming in from Indian Council of Medical Research, and it shows that the resistance percentage is so high. Acinetobacter baumannii is a serious organism, and you have around 70 to 80% resistance to this. So this is quite alarming, and this data is not 2025. It is around 2017 ish, so that 16 17, so it's quite old, but still it's alarming. Now when we talk about AMR, there are a lot of AMR that we can talk about, but there is a special patient population which needs mention. That patient population is usually a neutropenic patient. Which is a neutropenic patient? A neutropenic patient is usually a transplant patient or a patient who has oncology cycles going on, like they are on some kind of anti-cancer cocktail. These are the patients who are recipients of bloodstream infections which are AMR. So if you go into a hospital And if you go into a oncology infusion ward, and if you talk to the intensivist, he will tell you that gram-negative bacteria dominate oncology wards. These patients have very low immunity, they are neutropenic, and they need high-end antibiotics to treat. And slowly we will see that these antibiotics actually are getting resistant, and there is a lot of mortality which is happening in these patients, not because of cancer, but because of antimicrobial resistant bacteria. This is a very important element, usually not highlighted in presentations, not talked about in literature, but I have been there very closely, and that's why I wanted to bring this important piece to picture, is around the bloodstream infection in oncology, which is real world data, again coming in from India. You can also see that over a period of time, this has almost remained same. So through the CVC, central venous catheters, which are used, and the incidence rate is quite high in them from 1991 to 2008. Of course, this is dated, but it also shows that gram-negative CRBSI is specifically related with oncology, is specifically related with medical devices which are being used there, and also related with that patient population which is already fighting a battle of cancer, and you have an added disadvantage of AMR, and these infusions can only happen in that is a that's an important alarming uh, point which I want to bring about. Now, this is a simple graph which I wanted to bring to your attention, is that patients who have oncology, they have MDR bacteria, and they are usually cancer patients. So this intersection of patients are very vulnerable, and they have a very high mortality and morbidity. And you will see in the next slide that usually these patients have a lot of uh, deaths. So the mortality rate is usually very, very high, is around 66% versus 38%. So if there is a patient in a oncology ward, and this is Indian data, hard Indian data, what it says is that if you have a carbapenem resistant infection, 66% mortality rate exists, so which is double of what usually you will get as a mortality rate. So this is the why of the problem that we are talking about, why it is important in India, what the real world evidence is talking to you about the burden of antimicrobial resistance in India. It's a saying that yes, your cancer will be controlled, but you will die of infection, which is so unfortunate. You can just see this line, yes, your cancer will be controlled, but you will die of infection. So this is the truth for many onco patients who go to hospitals to get treatment of infusions, and then they die. They die of infections, not due to cancer, but they die due to infections because they are neutropenic, and they usually attacked by these carbapenem resistant bacteria. Now coming to the costs, so usually the costs are quite high in compared to the normal infections, and you can see that this is a recent one. I think this is 2024-25 study. The resistant group versus the susceptible group. You can see that the cost of stay is quite high here because of the longer length of stay in them. The consumable cost is higher in the resistance group. The surgical cost is also relatively higher, but what is usually higher is the cost of investigations, the pharmaceutical cost, and all that. So basically, if you are unlucky, if you get a antimicrobial resistant bug in while you are in hospital, then you are in for a large bill. If your insurer is not covering you, for that infection. He may cover you for the procedure, but he will not cover you for that infection. So then that's an out-of-pocket expense. So I think, yeah. After this, what I would like to talk about is what the government of India usually has done in this area. There has been a lot of effort in this area, but what the national expert consultations were held in 2022, and there is an integrated disease surveillance program which is run in all the state missions and different states in India to prevent this. I think the data from Indian hospitals goes into a glass repository, which is a international repository. I will come to that later on, of real world evidence of antimicrobial resistance. So this is about the why of the problem, why it is important to talk about antimicrobial resistance in India. How are we going to solve it? We are going to solve it through data. In today's session, we can solve it by many ways. One of them is data. So there are two basic repositories. One is European Antimicrobial Resistance Surveillance, which is EARSnet. Another one is NAMS, which is from US. The data which flows into the international repository is called Global Antimicrobial Resistance Surveillance System, or GLASS, as I told you in previous slides. Indian data also goes into GLASS. So if you want to do any research, if you develop a let's say a statistical algorithm to find patterns in antimicrobial resistance genes in India, you can get the data from GLASS, the Indian data as well as the global data, and do the data manipulation using that data, real world data from these two real world data sources. They have anonymized data inside their databases, so you can get the data, and then you can use different kinds of algorithms. We'll come to the algorithms later, and maybe you can use some complex I don't now no one uses Excel, so you will either use R or Python or some advanced statistical tool to analyze it. What you can do with data analytics and how you can solve it through data science is another point that I would like to mention. Is one of the things is predicting resistance. So suppose you there is a blood culture and you get a pattern, and if you have an algorithm to predict the kind of resistance it has, you can actually decide the type of antibiotic which can be given. You can identify resistance genes depending upon the length of the gene. So as per one of the studies, it's not on the slide, but from the information I would like to just tell you, it's found that if the gene length is smaller, then the complexity of the resistance is less. If it is medium, then the complexity is medium, and if the gene length is longer, then the complexity is longer. But that is true if you do a statistical analysis and you determine the resistance of the size of the gene, then you can predict the type of let's say resistance and the degree of resistance which is expected. You can also do a epidemiological kind of a modeling approach, where you can determine the spread of the resistance in the population. This is a different kind of algorithm. You will different kind of models will be used in this, the third point, but it would be usually looking at how the infection is spreading in that population. The last one is more on the personalized medicine area. So imagine a world where the moment your blood is taken, like today, if you go to a clinic, they withdraw your blood, and then they tell you that you have your HbA1c is this much, your LDL is this much, VLDL is this much, but no one tells you what is your what antibiotics you should get, what So basically, the profile that you will maintain in the electronic health record or electronic medical record, and the type of antibiotic that will be diagnosed in your blood will be matched, and then you will be given the antibiotic which you need and not the antibiotic which the physician thinks you would need based on data. So that is a future possibility which can happen. So this is a photograph from a recent publication which is talking about the same approach. What I was talking about is you will use a lot of I would say machine learning tools, not always AI. You don't need AI actually for this too much. You just need data coming in, and then you have to use a lot of machine learning to predict outbreaks and to do a lot of clinical decision support system. Basically, this would flow into a lot of HUR studies. The last one where you would have a normal prescription by a doctor and the antimicrobial resistance versus a clinical decision support system, which is a data-driven approach, giving certain kind of antibiotics and then seeing how much AMR is reduced by that clinical decision support system, which does a lot of statistical analysis based on EMR and EHR data. Now, this is what is possible across the globe, what is happening. So we went first to India, we saw what is the problem. Then we went to a little bit of data science and we saw what can be done. But coming back to India, okay, what will change? What will actually happen? So right now, what happens is you may or may not get a blood culture. At the physician's discretion, you get a treatment, which is what happens now. Very standard, very quick, and very appropriate for a lot of years. What can happen is that the blood cultures inform into a EHR database, which is maintained for you. Your blood cultures are you have data for your blood culture, you have data for your population's blood culture, you have data for the usual antibiograms which are there in your population, so you know is there an outbreak of certain antibiotic, certain bacteria, is there a specific resistance pattern in the population or not, and are you a part of it, whatever. So there is, so this data which is captured once you get the blood, your blood cultures are graded and they are a part of the standard EHR. Then that data goes into a statistical model. Now the statistical model can be any of these statistical models. So right now it's not our duty to go into all of them because they are a lot, and it is not possible for today's discussion to go into all these kind of different kinds of algorithms. But what I can say in a very quick way is random forest RF is a usually useful technique in today's world, which is possible. RF, you just remember RF, maybe which is random forests, which have been more useful for real world evidence applications in antimicrobial resistance. But all of these different algorithms, be it decision trees or support vector machines or whatever, different kinds of regressions, they are also useful. What they give is they give area under curve, and based on the area under curve, you select a specific treatment. So you don't select what you don't need, you select what you need only based on the type of bacteria, and that would prevent future AMR. And your data will also become a part of the large data set. So what was prescribed, so it will also inform a lot of prescribing patterns. So this is something which is useful for the clinical practice, where you have a lot of EHR EMR data being processed, and this is I would say the place where if you do this kind of analysis and you do this kind of analysis, of course this would have a lot more costs, but if you do a cost effectiveness analysis, I think in the longer run you would save a lot of money, because you are not spending for management of microbial resistance in future. So the extra cost of treatment of a antimicrobial resistance bacteria would be borne by these kind of data analytic models. So I think it would also be quite cost effective when we compare it to the usual way, provided we have a database of electronic health records. We have good statistical models which can do real-time analysis or quick analysis at least for the doctor, and then he can prescribe you the right treatment, and that would bring down the AMR. So this is the approach of real-world evidence for AMR. You can treat AMR with many things, and that is the last slide. You can do by antimicrobial stewardship, you can do guidelines, you can do education and all, but from a data science HEOR angle, the previous slide is the place where you can really put a dent on this kind of issue, especially in a country like India or any developing nation. So this is more or less about my presentation. What I would like to conclude is that, yeah, if you do a data driven approach, that would be more evidence based and more safer and more cost effective for the government or for the private sector going ahead, compared to what is happening today. But this is something which is not happening. It needs institutionalization, it needs standardization, and maybe there could be some progress in this area in future. Yeah. Your questions are welcome, please.
Thank you for that insightful and thought-provoking presentation, Dr. Pinaki Ghosh. You have given us a lot to reflect on regarding the role of real-world evidence in HTA and how we can strengthen the efforts to combat antimicrobial resistance in hospital settings. Now, the floor is open for questions. Any questions from the audience?
Yeah, thank you, Dr. Pinaki. It was really very insightful presentation. And I encourage all the participants to ask questions if they have any. Otherwise, Dr. Pinaki, since you have participated in the second fellowship, now we have grown. The entire ecosystem is too big. So whenever you visit India, we look forward to host you and see how even we can work together on any project, or if there is anything on which we can collaborate and work together.
Yeah, definitely.
Just
I
let
think
me know whenever you are traveling to India.
yeah. Of course, I would let you know, and I think KIHT firstly providing this platform to me. I'm very honored for this. But I would say from a angle of substantiating the HTA skill set in a larger population is very important. And I remember the hands-on sessions, of course, which were there during the fellowship program. I think they are still there in the different fellowship programs, and that is a very rare commodity, because anyone who is listening, you have to pay a lot of money, okay, if you want to learn economic modeling. And you have to go either to UK or to a Western world to learn high quality economic modeling, or maybe if you are doing a master's in health economics. But here you have experts teaching you modeling on Excel sheets. which is very rare. It is difficult to get such opportunities where you do hands-on, not theory but practical. So I think that is a very important aspect of hands-on skill transfer, which I would say. And then once the seed is sown, then you can prosper into a lot of different kind of areas. And economic modeling is an area which is extremely important in health economics, outcomes research, and market access. And as the field matures, you will have less and less opportunities in the area of systematic literature reviews, but you will have more and more opportunities in the area of data-driven approaches like economic modeling or data science in health economics. So I think this is a door. Uh, I mean, this is a small opening into a big universe of health economic data science through Kalam Institute, and I would definitely try to visit. But uh, all the students who are listening, whatever background you are in, you definitely consider doing this kind of activity. You can also do courses from PGIMER Chandigarh, uh, and you can also enroll into MSc programs. But here is a place where in 3 days you will know how to make a Markov trace. You will do a one-way sensitivity analysis, and you will create an ICER. Own your own model with a data from Dr. Aniben Basu. And I think for me also, when I went there, I learned a lot of nice information from him. So I think that what I would feel from Indian perspective is there is a lot of influence on systematic literature reviews, which is okay, but the future is in a lot of data-driven science in health economics. I am one of the products of that school of thought.
Wow, fantastic. And thank you for those kind words, Dr. Ghosh. And it's like for all the participants, as Dr. Ghosh mentioned, you have to spend a lot of money to even understand those concepts which we teach. And whatever we are charging, it's bare minimal for that, that high level quality training which we, disperse during this 5 days fellowship program. So
Yeah.
it's really exciting, and as you have already mentioned that it is a way forward to the future. So I invite all the participants for the next year's fellowship. We would again be conducting 11th International Fellowship on Health Technology Assessment during March. Because we hosted it recently, I need to decide on the dates. That will be open on our website and on the social media shortly. I encourage you all to participate. And also, in case you have already participated and you really want to learn more, you want to join hands, and if you have any exciting topics where you need help, you don't understand where to go, you can always write to me, and we will be there to help you, handhold you through the project, and we'll give you an opportunity to present that project during World Health Innovation Forum, which we host every December. So with
Yeah.
this, do we have
I think,
any
ma'am,
more
there
questions?
is a question. Yeah, I think there is a question here. They say that there is a lot of guidelines. So how can you bring a behavioral change in the providers? So there is one of them is to bring it into the curriculum of the practitioners who have the power to prescribe. That would include, I would say, PharmDs and also MBBS curriculums about the necessity of AMR and the necessity to adhere to it. I would say another important part would be conducting a lot of CMEs from the government to encourage at least the use of rational antimicrobial prescription in the government hospitals, because from a government perspective, you can first control the public hospitals, and then slowly it will percolate into the private sector. But it needs to start from center of excellences across India, like AIMS, JIPMER, who are the centers of national prominence. than from a small hospital somewhere, because
Very rightly.
that no one will follow. So yeah, this I think has to
Yes,
be
very,
the
very rightly
platform.
said. Yeah.
Yeah.
Yes, yes. Thank you, Dr. Ghosh. You very rightly said. In addition to this, in India, I would like to again mention, as I mentioned before during my presentation, that we're also a price monitoring resource unit for National Pharmaceutical Pricing Authority. As HTA has grown in the country, one resource hub in every state. Similarly, National Pharmaceutical Pricing Authority has also created different hubs, and we are one of the hubs among those centers. And this role will be taken care by them, because we do lots of, so it is a responsibility of these PMRUs, price monitoring resource units, to could enhance awareness in the ecosystem on antimicrobial resistance, on government policies, on drugs, and capture violations from the market. So as important as it is from the aims like institution to enhance the awareness, as equally PUs are given this responsibility to create the environment awareness in the ecosystem. So that is the way forward, and that's how we see the final future on this topic. Yeah. Yes, any more questions? Do we have any more questions?
Hello.
Yeah, hi.
Okay,
Yeah, so
then.
good afternoon, sir. I'm
Yes.
Tanmay Kulkarni, the secretary of SPOR BVDO student chapter.
Okay.
So
Hi.
first of all, sir, thank you for an enlightening session. It was great to learn from this. So I just had one doubt. So you mentioned about ways to combat AMR in hospital, right? So I just wanted to ask that what role does real world evidence play in identifying populations which are at risk for MDR infections?
See,
So how
there
can
are
we
some,
identify them?
yeah, there are some populations which you don't need real world data.
Okay.
If the patient is neutropenic, if the patient has low immunity, primarily he will be a transplant patient, he will be a onco patient. Those patients have, definitely they will capture the gram negative
Yeah.
antimicrobial resistant strains only. They are the most susceptible people in a hospital.
Yeah, correct.
People who are neutropenic. Apart from this, we need to look at any outbreaks in the hospital which have happened in past, and
Okay.
keep them ready, like any kind of, let's say, acinetobacter outbreaks in past and all that. In which populations, for example, maybe pediatrics, that can be possible. So these two patient population, and also geriatrics. I think you would not see this kind of thing in mostly, let's say, emergency, because people come in, it's a short duration kind of thing. You will usually see this mostly in ICUs, where the patient stay, and you would have chemo cycles going on, chemo infusions going on. Let's say you have patients coming in for chemo cocktails, where you have different kinds of chemo drugs given to them. Those patients, as I mentioned, in India especially, these kind of patients have, definitely they will get a antimicrobial resistant strain. So there, the anti and stewardship is extremely important. The hand hygiene is super important. All the infection control mechanisms have to be very, very important for those populations who are neutropenic, immunocompromised, going post transplant, oncology, pediatric, and geriatric. This is like a susceptible population. If the hospital has a hospital management information system, HMIS, if the hospital has HMIS and you can access it as a hospital pharmacist, then you can go back and do a regression to find out what, I mean, if you have anonymized data in Excel, you can do regression to find out if the infection was avoidable or unavoidable, and which kind of antibiotics were prescribed, whether they were high end or normal antibiotics, and also if the length of stay was longer or shorter, and what kind of antibiogram they had. From this analysis, you can actually predict what is the specific pattern of antimicrobial resistance in that hospital. Now, this kind of thing is very hospital specific. If we the slide that I presented was primarily if you have a large data set from to analyze from EHR, but from a hospital, if you know which kind of antibiotic was prescribed, what was the patient population, then through regression you can apply. You can still know some risk factors which were there. You have to assign the dependent and the independent variables, and then you may be able to predict that, okay, in my in my hospital, which is the most vulnerable. But from literature, these are the most vulnerables: neutropenic, immunocompromised, transplant, chemotherapy patients are the most. If you read literature, you will find a lot of good information from, I think, Dr. Gafoor from Chennai. He has published a lot of things on this specific patient population.
Okay, thank you, sir. Also, as a working pharmacist in a hospital, I've also seen that most of the infections which we get in the hospitals, the MDR ones, are associated with devices such as Foley's catheter or the endotracheal tube. So, how can we control that?
Devices, you try to select devices which have antimicrobial impregnation.
Okay.
Yeah, so basically CVC, normal CVC versus CVC which has a impregnation of, let's say, any kind of minocycline, rifampicin, silver, maybe. That would be, so any kind of impregnated or ionized CVCs which have ionized surfaces. They are also very good in reducing the BSI rates and the CRBSI rates. So any kind of, so this is one of the things. Other part is that if you usually can compare, let's say, what is the infection rate of a coated versus non-coated CVC, you will find non-coated. Coated CVC is less than non-coated. Non-coated is higher. Same way, PIC versus port. PIC, the infection rate is higher. Port, the infection rate is less. But when you go for these higher end devices, a coated CVC, a port in patients, or any kind of better treatment, and then there will be a cost associated with it, the incremental cost.
Correct.
At your end, you can draw a simple decision tree to inform the hospital that if you buy extra a device of extra cost, then you can save a lot of length of stay for your hospital, and also the patient bill. So patient bill is a different matter because in India it's an out-of-pocket market. So insurance is not paying the cost of infection, but the length of stay is reduced for a non-AMR patient versus a AMR patient. AMR patient, the length of stay is longer. The length of stay is longer, the patient stays longer, the hospital loses money because there are less number of admissions which happen and less number of procedures which happen due to this, and the profit and loss of the hospital is not favorable if the length of stay increases. I have a separate presentation on this. This is a very different topic, but it on the contrary to the normal belief that if a patient stays longer in a hospital, the hospital earns more, is actually wrong. If the patient stays anything more than 48 hours to 72 hours, then the hospital starts losing money. So this is more from a hospital perspective why you should reduce the infections.
Okay, thank you so much, sir.
Yeah, because they will spend more money, right, to buy devices.
Absolutely. Thank you so much, sir.
And yeah, I think you are from my alma mater, so thank you for this.
Yeah.
Yes.
Wow, what a wonderful discussion and what wonderful question. So, with this, it was such a successful webinar. Thank you, Dr. Ghosh. We would be closing the webinar now. Thank you, participants, and thanks a lot, my lovely team who have worked so in the back end to make this webinar successful. And we will be in touch, Dr. Ghosh, separately to take many things forward from now onwards. Okay.
Absolutely.
Thank you, participants. Goodbye, everyone.
Thank
Bye-bye.
you. Thank you, everyone.
Thank you again.